Very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again in our Saturday academic program. Today's presenter is Dr. Shivakumar Thiagarajan. He is Associate Professor and Surgeon in the Department of Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. He is going to speak on the landmark surgical trials for carcinoma of larynx and hypopharynx. So I welcome Dr. Shiva. Dr. Shiva, please go ahead with the presentation.
Yeah, thank you, Dr. Poonam. So this presentation is going to be basically on landmark trials in larynx and hypopharynx. I mean, most of the landmark trials are on larynx, and we'll see how the data has been extrapolated to hypopharynx. So can I share my screen? Yeah, it's possible. Yeah. Just a moment, I'll just there it is. Is it visible?
Yes, we can see.
Yeah. This talk, what I understood was it was on landmark trials in larynx and hypopharynx. So essentially, when we look at the landmark trials for larynx and hypopharynx, these are basic. Sorry.
Sorry, Dr. Shiva, I think somebody spoke, someone joined, and there was some.
Okay.
Sorry.
So essentially is based on the organ preservation protocols. And of course, we would see the other sort of landmark trials. So when we talk about landmark trials, what do we mean by landmark trials? These are essentially trials, which are in most often randomized controlled trials, which are often practice changing, So we are going to just look at many of these trials in larynx and hypopharynx, which has changed our practice over the years, and even till date, we are practicing most of this. So just to give a brief introduction, the main function of larynx, as we all know, in the order is respiration, airway protection, and phonation. So the most important thing is respiration, protecting the airway, and then last but not the least is phonation, which is a very important function for us, because that's the most important socio-cultural function that the humans have as of today. And 30% of patients are willing to accept lower survival in view of a preserved larynx. Okay, and so such thoughts, the profound desire of large part of the patient population to have their organs preserved led to many of the organ preservation trials that started way back in the early 1980s. So just to give you a ballpark figure of the incidence of laryngeal cancer is anywhere between 1.2 to 8.18 per 1 lakh population in different regions of the country. This is Indian data. And again, this is the Indian Globocan data, where you can see the hypopharyngeal cancer is within the top 20 hypopharynx, and larynx are within the top 20 cancers in the human body in India. And of course, it's not figuring in the top 10. As we can see, it's the lip and oral cavity, which is the third most overall cancers that you can see in India, in the world as well. And the larynx and hypopharynx is between 10 to 20 in position. So just to give a timeline, surgery was essentially the mainstay of treatment in the 19th century, when the first total laryngectomy was performed in 1873 by Billroth, and then different types of modifications to it, and the perfection of the technique was being done over the years. With the advent of radiotherapy in 1903, after the X-rays were found, and then the radioactivity was later discovered by Marie Curie and Becquerel, the use of radiotherapy in various treatment for cancers came into vogue, and people started using. Of course, the technology was nascent, but still there were indications where they were using it sparingly. But it was more put into use in the later part of the 20th century. And of course, the lasers were, the CO2 lasers were, came into existence somewhere in the 1970s, and it found its application, especially for larynx and hypopharyngeal cancer. And the organ preservation protocols, starting from the VA trial, and there was a first initial publication in ASCO in 1982, which put forth the thought process of organ preservation. Subsequently, that was tested in multiple randomized controlled trials, as we will see in our presentations. So here in the presentation, I will be sticking on to the, the practice changing trials, especially randomized controlled trials or systematic review of randomized controlled trials. Of course, there are a lot of literature on laser, especially, which are like prospective, retrospective series of, various, pioneers in laser surgery of such as Steiner, Perity and all that. But we will just stick to the randomized trial. Of course, they have shown that laser can be effectively used from T1 to T4 cancers, but the evidence is strong for T1, T2 laryngeal cancers. Of course, hypopharyngeal cancers as well, but mostly for T1, T2. Now, coming on to early glottic cancer, the question always is it radical radiotherapy versus transoral laser surgery? So what evidence do we have? So before we go there, the goal of organ preservation, either in early glottic cancer, we need to understand is to achieve cure with best functional outcome. So it's not just enough to have a good oncological outcome in a T1, T2 laryngeal cancer. Also, the functional outcome matters in such patients. Of course, in all patients, more so in T1, T2 laryngeal cancer. So these are the various, studies. The first study is a randomized controlled trial, whereas the rest are, prospective series. We'll just dwell into the, the one randomized trial that was, there were only two randomized trials. One is by Alton published in 2014, wherein you can see the number of patients that were accrued. It was 28 in RT arm and 32 in the transoral laser surgery arm. And at 2 years, they had equivalent oncological, outcomes. Larynx preservation data was not available, but then looking at the oncological outcomes, I think both are similar percentage. And voice quality, however, the overall voice quality was similar in both arms. The voice was more breathy in the transoral, in the laser surgery arm, and less hoarse in the RT arm. So, of course, there was no clear-cut, differentiation between the two arms. And of course, various studies suggest that the voice outcome is slightly better in the radiotherapy arm, especially when the lesion is across the anterior commissure going on to the opposite cord, the T1B lesions and the T2 lesions especially. So this is the other, randomized controlled trial, which compared transoral laser surgery versus radiotherapy in T1, T2 laryngeal cancers. Again, these were small numbers, 52 patients. Most of them were T1A, all of them in fact were T1A laryngeal squamous cell carcinoma. And in this prospective, in this randomized trial, the oncological outcomes of both treatment modalities, especially for that is T1A in this group, were similar. Of course, they have not, the larynx preservation rate also was similar. Of course, they have not reported the voice related outcome in this particular trial. Now, we had two randomized controlled trials, which spoke about early surgery versus, transoral laser surgery versus radiotherapy. Now, we all know that there are also open partial laryngectomies as well. Open. I would request all those who log in to please kindly, switch off your mics so as you log in, so that the flow doesn't get disturbed. So this, this Cochrane meta-analysis, systematic review and meta-analysis looked at radiotherapy versus open surgery versus endolaryngeal surgery, with or without laser, for early laryngeal squamous cell carcinoma. Now, both of these, RCTs were published after the two randomized trials where, actually came out in press. So this trial reported saying that only one trial was recruited in a substantial number of patients with glottic carcinoma, that is somewhere in the Eastern Europe in 1990s, and it was a multicentric randomized control trial. And so the trial was started in 1979 with 239 patients evaluated, of whom 238 had glottic laryngeal cancers, and patients were followed up for 5 years for recurrence-free survival rates. So this trial was not good enough because at that time the radiation delivery techniques and everything was not standardized, and also they were not the techniques were totally different and more so, let's say, primitive. And so they concluded that there is no good evidence available from randomized trials to guide treatment choice. So this was the conclusion before these two randomized trials that we just discussed. So this is a bit more in detail about that. There were T1 tumors, and the 5-year survival rate was 91% following radiotherapy and 100% following surgery. And for T2 tumors, it was 88 and 97% following surgery. And so then there were no significant differences in survival between the two groups. Again, for T1 tumors, the 5-year survival, disease-free survival, the initial disease-free survival rate was 71% with radiotherapy and 100% with surgery. And for T2, it was 60 and 78% respectively for radiotherapy and surgery. So only the latter comparison was statistically significant, that is for T2 cancers. But however, the data, they couldn't conclude, as to which modality was better for any of these comparisons that they sought out to begin with. But then what we know is the prospective retrospective studies show that there is a good oncological outcome with transoral laser surgeries for both radiotherapy and transoral laser surgeries, and for larynx especially, but not so much so for hypopharynx. Larynx, for glottic cancer, there is more evidence than the supraglottic malignancies. And these are the two randomized control trials. Both the two randomized trials were for a glottic subsite. The supraglottis, again, is prospective retrospective series that we have. So there are multiple systematic reviews of these various prospective retrospective studies comparing endolaryngeal surgery and radiotherapy. None identified any randomized trials, and they varied in stages, the staging criteria, the types of studies. Many included comparative studies only, some case series, and outcomes for study inclusion were not properly mentioned. So those were for early glottic cancers. So for early glottic cancer, again to recapitulate, we have only two randomized trials, both for glottic malignancies. And for the supraglottis and hypopharyngeal sites, these are essentially prospective retrospective studies and systematic reviews of these prospective retrospective studies. So if you have to go by those systematic reviews, you have good solid data for glottic malignancies, and in all the guidelines you have transoral laser surgeries or partial laryngectomies as one of the treatment options for early laryngeal cancers, especially the minimally invasive, the endoscopic laryngeal surgeries, that is using laser. Those so there's good evidence for glottic followed by supraglottic, not so much for hypopharyngeal cancer. Now coming on to advanced laryngeal and hypopharyngeal cancer, there were quite a lot of landmark trials in this setting. So basically, it is on organ preservation. We have just seen the reasons for why organ preservation strategy was favored by the clinicians based on the the desire of the patients from various studies that were seen before that. So the various strategies were definitive radiotherapy, induction chemotherapy followed by radiotherapy, and concurrent chemoradiotherapy. And the basis for this was that concurrent chemoradiotherapy was that chemo responders were more radiosensitive, it downstages disease, and so have better radiotherapy response, and it also reduces the rates of distant metastasis. Now let's see each of these landmark trials one after the other. So the first in this series is the VA trial, the Veteran Affairs trial, wherein stage 3 and 4 resectable squamous carcinoma of larynx were included. There were 332 patients. So there were two arms. One was total laryngectomy followed by postoperative radiotherapy, and one was induction chemotherapy with cisplatin 5-FU of 2 cycles. And based on the response, if the patient had a partial or a complete response after 2 cycles, they were given a 3rd cycle, and then the patient received radiation of 66 to 70 grays standard fractionation. It's not 76, I think it is 70 gray. And less than partial response after 2 cycles underwent total laryngectomy. So in both the arms, there were 166 patients each, and both had a comparable 2-year survival at 68%, and the larynx preservation at 2 years was 64%, and the pattern of recurrence though was different, as you can see here in this table here. So in the non-surgical arm, the pattern of recurrence was predominantly roco-regional. If you can see here, 12 and 8%, whereas in the surgical arm, the relapse or the recurrence was predominantly distant. So there was pattern of recurrence in these two were different. The long-term study that was published subsequently in 1988 showed quality of life. Sorry, not cure impaired. There was improvement in the quality of life. Sorry for that typo error. Improvement in the quality of life on the long-term follow-up. So significantly, there was a better quality of life scores related to, this was related more to freedom from pain, better emotional well-being, and lower levels of depression than anything related to preservation of speech functions, especially in the non-surgical arm. And this trial is what paved way for the organ preservation strategies as a treatment option for laryngeal cancers. This trial had patients predominantly with supraglottic tumors, and most of the tumors were T3 and N0. There were, a good, salvage laryngectomy was required in 44% of these patients, with salvage laryngectomy being done more in stage 4 cancers compared to stage 3, which was statistically significant, as you can see. And the large proportion of recurrences occurred locally, which was also evident in that recurrence pattern, that table. And all of them occurred within the first 1 year. The salvage laryngectomy was seen more often in glottic primaries when the cords were fixed. In T4 larynx, 56% of them required a salvage laryngectomy, and when there were cartilage invasion. So these, factors probably hinted at the scenarios where laryngeal preservation may not work. So that is what we have learned over the years, and we definitely have learned those lessons, and we definitely not offer, larynx preservation for when there is cartilage erosion or T4 larynxes, but not so much so the first two factors. So the success of these laryngeal preservation for laryngeal cancers led to the extension of this concept to hypopharyngeal cancers as well, where laryngeal preservation was attempted with similar trial designs. So this was the EORTC trial, probably the probably the only trial which included the hypopharynx subsite. And here 80% of the patients were T2 to T4 squamous carcinoma of the piriform sinus, whereas 22% were from the supraglottis. So totally there were 194 patients, sorry. And there were two arms, basically. There were two arms. One was again total this arm which had upfront surgery. The other one was induction chemotherapy with cisplatin 5-FU, followed by, based on the response, patient would receive undergo surgery or radiation therapy. Now here, you need to understand here patients who had only complete response, who had at least partial response, or a but given after 2 cycles, when the patient had at least a partial response, received the 3rd cycle, and only those who had complete response went on to receive radiation therapy of 70 grays. Whereas anything less than PR or progression, the patient underwent a salvage laryngectomy. The patients had comparable local regional control rates and 5-year overall survival rates, with larynx preservation of 35% at 5 years. We need to look at this study in a bit more in detail. Of course, we know the DFS OS were all okay. At 3 years, the larynx preservation rate was 48%, and at 5 years, it was 35%. There was no difference in the local regional or distant metastasis rate in this trial. The one thing that we need to understand is it was planned for a sample size of 270, but the accrual had to be stopped at 220 patients. There were quite a bit of selection bias. Only patients with complete response on induction chemotherapy proceeded to receive radiation, and all poor responders received surgery. So this might have worked in benefit of patients who received non-surgical treatment option. And you can see that nearly 40% of the 41% of the patients received surgery in the induction chemotherapy arm. So again, there was a good number of patients who underwent salvage surgery in this non-surgical arm. So these are some of the things to ponder about. And the long-term, the 10-year results of this EORTC trial showed that this strategy did not compromise the disease control or survival and allowed more than half of its survivors to retain their larynx. Now, here, the thing is that all these patients, many of these patients died of various non-cancer-related deaths, which was more evident in the next trial that we will be discussing here, and that is the RTOG 911 trial. So after the EORTC trial, also there was some amount of evidence with concurrent chemoradiotherapy that was emerging subsequently. This trial was designed, which had the stage 3 and stage 4 squamous cell carcinoma of glottis and supraglottis. Overall, there were 547 patients randomized into 3 arms. Arm A was induction chemotherapy with 5-FU cisplatin of 2 to 3 cycles, followed by definitive radiotherapy of 70 grays. Arm B was concurrent chemoradiotherapy, 70 grays with 3 weekly cisplatin of 3 cycles. And arm C was only radiotherapy at 70 grays. And surgery for selected patients only was done. Neck dissection if only a single node of greater than 3 centimeters or multiple nodes involved on initial clinical staging was done. And salvage laryngectomy only if there was a recurrence subsequently. Patients with less than partial response after 2 cycles of PF underwent laryngectomy followed by adjuvant radiotherapy, like what was seen in the previous 2 trials. So at a median follow-up of 3.8 years, the concurrent chemoradiotherapy arm had a higher laryngeal preservation rate of 84% compared to the other 2 arms, and no significant differences in the overall survival between 3 arms. And however, the grade 3 toxicities were slightly more in the chemotherapy-based arms, especially the sequential and the concurrent chemoradiotherapy arms. But there are a lot of other things that we need to look into this trial as we discuss this further. Now, let's look at this trial in a bit more detail. First, let's see what are the percentage of patients who required a salvage laryngectomy in this RTOG 911 trial. So 129 patients of the 547 patients required salvage laryngectomy, and the salvage laryngectomy rates were kind of higher in the radiotherapy alone arm, followed by induction chemotherapy and radiotherapy, and the least in the concurrent chemoradiotherapy arm. The incidence of complications that is related to these 3 arms were in complications following surgery, salvage surgery was anywhere between 52 to 59%, and it did not significantly differ in the 3 arms. And the local regional control rates following surgery, was 74% for arm 1 and 2, that is the chemotherapy arm, and 90% for the radiotherapy arm. So the control rate was much better when the patient received when the patient had recurrence after only radiotherapy and when it could be salvaged. At 24 months, the overall survival was, more 69%, 71, and 76%, though this was not statistically significant. Now, this trial, the long-term results were published at 10 years long-term results, and they found that the induction chemotherapy followed by RT and concomitant cisplatin chemoradiotherapy showed similar efficacy for the composite endpoints of laryngectomy-free survival. Now, the main criticism for this trial was laryngectomy-free survival. What does laryngectomy-free survival mean? So that is when the patient has an intact larynx at the time of death, also was considered as a laryngectomy patient as not having an event. If the patient dies with an intact larynx, is also okay. So that was considered fine, which actually doesn't serve the purpose, right? So the definition of laryngectomy-free survival was, was highly criticized. Instead of taking overall survival, they just looked at the laryngectomy-free survival. And also there were quite a bit, though there was no difference in the induction chemotherapy and the concurrent chemoradiotherapy arm, there were a lot of non-cancer related deaths in the long term in the 10-year, follow-up publication. And this was attributed to what is, to aspiration, which was considered as one of the, complications following, radiotherapy or chemoradiotherapy in these patients. So that is a very important aspect that needs to be looked at, and these patients have to be closely followed up, because otherwise these patients can have these aspiration pneumonia and subsequently death. Now let's go on to the, just a minute. Yeah. Okay. So the so we have seen the VA trial, the RTOG, and the EORTC trials, the 3 main trials, and subsequently there were a few other trials that were done. So one of them is the Glottic trial, wherein it was a randomized trial of induction chemotherapy with cisplatin 5-FU without docetaxel for larynx preservation. So they had about 213 patients, and they were randomized into 106 and 100 patients. And if you can see it here, I'll just, okay. So the sites as to the hypopharynx and larynx, the number of patients with hypopharyngeal malignancies were slightly more compared to larynx malignancy here. So this is another trial where the hypopharyngeal malignancies patients were were included in the randomized trial. And here the patients, were evaluated after this induction chemotherapy, 2 cycles of either TPF or PF. And then patients would, if partial response or more, patient would undergo, larynx preservation with radiotherapy or chemoradiotherapy. If they're less than partial response, then the patient would undergo surgery. So in these 2 arms. So they found that the TPF, the 3-drug arm, had superior overall response rate and larynx preservation rate, however, with slightly higher toxicity. And there was no difference in the OS and the disease-free survival in these patients. The other trial is the Glottic trial, again from the French group, and it had a higher, had mostly T3 larynx, and it was planned for 300 patients. However, the patient was stopped at after 68 patients were accrued. Due to the high toxicity that was encountered in this trial following chemotherapy, and it was randomized into total, surgery and induction chemotherapy 2-3 cycles. If the patient had greater than 80% of tumor regression, the patient would undergo radiotherapy, otherwise surgery. But however, this trial had to be stopped, so nothing much could be drawn. Am I audible now?
Yes, Dr. Shiva, you are audible.
Yeah. So that is with the Glottic trial. The other trial that you probably would want to know about is this Susan Erber trial from the University of Michigan, wherein there were 97, this was not a randomized trial, however, the concept was kind of interesting, wherein the 97 eligible patients received a single cycle of neoadjuvant chemotherapy, which is cisplatin 5-FU, less than, actually it is more than 50% response received concurrent chemoradiotherapy, and then adjuvant chemotherapy of 2 cycles for complete responders, and less than 50% response underwent salvage surgery. And following concurrent chemoradiotherapy, there were 29 patients who had to undergo salvage laryngectomy. So this was one, another trial, though not a randomized trial, was an interesting organ preservation strategy. Now, we have seen most of these trials had induction chemotherapy, but the use of induction chemotherapy over the years was cisplatin 5-FU. And then, however, subsequently the use of TPF, you could see that the Glottic trial used TPF regimen. Now, there are two trials, the TAX-323 and the TAX-324, which showed that the 3-drug induction chemotherapy had a better response rate and also added to the progression-free survival. So we'll just look at these two trials in a bit. So the TAX-323 was cisplatin 5-FU TPF in unresectable head and neck cancers. So 323 was in unresectable head and neck cancers. You need to remember that. And, you know, following which the patients received four cycles of 3-weekly TPF, Docetaxel, Cisplatin, and 5-FU, or 4 cycles of Cisplatin and 5-FU. And then they went on to receive radiotherapy of 70 grays over 7 weeks. There was a planned neck dissection in between. Some patients underwent neck dissection if it was deemed resectable based on certain criteria, if there was a good response in the primary, and surgery for residual disease if that was deemed resectable at the end of radiotherapy. So the primary objective here was progression-free survival. So here there were about 181 patients and 177 patients included for intention to treat analysis in these two arms, that is TPF versus PF, and patients who showed, of course, the toxicities were more with the TPF arm. And what we need to see here is this table here, wherein it predominantly included the oropharyngeal subset. However, there were a good number of larynx and hypopharynx patients. And the response rate was pretty, patients with complete and partial response percentage was, above 50%, close to 60% even. So the progression-free survival when the patients received TPF was higher compared to those who received only PF, 11 versus 8.2 months, which was statistically significant. So that was the TAX-323 TPF versus PF in unresectable head and neck cancers, which included hypopharynx, larynx, oropharynx, and oral cavity. Majority being oropharynx. You need to remember this. The next is TAX-324, which had this also included certain amount of resectable head and neck cancers. So again, this was cisplatin 5-FU alone with or without docetaxel in head and neck cancers. So here you see patient receives PF or TPF 3 cycles once in 3 weeks, and then the patient undergoes concurrent chemoradiotherapy. Now here for concurrent chemoradiotherapy they have used carboplatin and surgery if necessary. And here the primary objective was overall survival. And you need to understand the TAX-323 was on unresectable head and neck cancers, and the primary objective outcome was progression-free survival, whereas 324 also includes resectable head and neck cancers, and it uses 3 cycles of concurrent induction chemotherapy compared to 4 cycles in the previous 323 study. And then the patient undergoes concurrent chemoradiotherapy here, whereas in the 323 it was only radiotherapy, concurrent chemoradiotherapy with carboplatin, and salvage surgery if deemed necessary. So again, predominantly oropharyngeal subsite, but there were a good number of patients with larynx and hypopharynx as well. And patients with who received TPF showed a good overall survival, which was of 71, almost 71 versus 30 months. That was absolutely terrific, and TPF and that was highly statistically significant. But you can see that it was all mostly oropharyngeal primary. Right. The other trial, which had some amount of patients with larynx and hypopharynx, were these DYSPHAGIA and paradigm trials. But however, both these trials were negative trials for various reasons. But I'm just mentioning it here for the sake of completion. And the accrual did not complete, and there was no difference in OS and DFS. There were serious adverse events in the TPF arm, and only 14 to 19% were laryngeal subsites. And there were no concurrent regimens used. So the TPF followed by concurrent chemoradiotherapy was used either with hydroxyurea or docetaxel. So the regimens of concurrent chemoradiotherapy was not standard. So that's why I'll not go into these two trials, but you need to know that the DYSPHAGIA and paradigm trials were negative trials where they looked at the induction chemotherapy with TPF followed by concurrent chemoradiotherapy or upfront concurrent chemotherapy alone, these two arms. So just a word about the MACCH-NC trial. We all know that the concurrent chemoradiotherapy arm adds to the overall survival by at least 4%, and the platinum-based chemotherapy regimen adds to the survival. Both in the adjuvant or induction setting, there was no benefit in survival. So that was again seen in the updated MACCH-NC randomized trial of 93 randomized trials with 17,000 plus patients. That's what we have seen, and we have seen advantage with use of chemotherapy in the concurrent setting rather than in the other two settings. Now, the other thing that we need to know about is the dysphagia and aspiration related structures. So this was first described by Isbruch, and he identified the pharyngeal constrictors, the supraglottic larynx and the glottic larynx as structures at risk and deemed them the dysphagia aspiration related structures. So when patient receives radiation to either oropharyngeal primary or hypopharyngeal primary, these structures are irradiated and can lead to aspiration when these structures are in the field of radiation. So there's currently a randomized control trial that is ongoing, looking at oropharyngeal and hypopharyngeal primary, looking at the sparing of these dysphagia aspiration related structures and the outcomes in terms of survival and also function, which is measured by MD Anderson dysphagia inventory and also using video fluoroscopy as well. Now we have seen all the induction related, induction chemotherapy followed by radiotherapy alone, followed by chemoradiotherapy in the various trials that we've seen so far. Now there is an addition. We'll see two trials wherein there was addition of cetuximab, that is addition of some targeted agents here. So cetuximab was being used for radiotherapy plus cetuximab for squamous cell carcinoma of the head and neck, wherein here in stage 3-4 head and neck squamous cell carcinomas, the overall 424 patients, weekly cetuximab concurrent with definitive radiation was used in 211 patients, and only radiotherapy was used in 213 patients. With a median follow-up of 54 months, when weekly cetuximab was used with radiation, there was an improved 3-year overall survival and improved 2-year progression-free survival as well. And increased, but however, there was certain toxicities such as the skin related toxicities such as rashes, but otherwise the rates of grade 3 toxicities in both the arms with that is with or without cetuximab were more or less similar. Again, in this trial, most of the patients were oropharyngeal malignancies and larynx patients were few, and also most of the patients with laryngeal cancers were mostly T1, T2 cancers. So predominantly this holds true for oropharyngeal malignancy more so than for laryngeal or hypopharyngeal malignancies. The next is the trampoline trial, wherein induction, this is a phase 2 randomized trial, wherein induction chemotherapy was followed, induction chemotherapy was followed by, just a minute please, So induction chemotherapy followed by either chemoradiotherapy or bioradiotherapy for larynx preservation. That is the trampoline trial, which is a phase 2 randomized trial, wherein there were around 149 evaluable patients, 126 in the responders arm. So all these patients were given induction chemotherapy, and then subsequently the responders went on to receive either concurrent chemoradiotherapy with cisplatin or concurrent cisplatin plus radiotherapy, and the non-responders went on to receive either surgery or radiotherapy. Here you can see 16 patients underwent surgery and 7 patients underwent radiotherapy alone. And here there was no evidence that one treatment was superior to the other or addition of cetuximab could improve outcome. The toxicities, however, were similar, but then this was a phase 2 trial which the authors concluded needed to be tested in a phase 3 trial, which was never done for various reasons. And but then this just needs to be mentioned. You need to know that the cetuximab trial, there are two. One is the bonus study, which was predominantly used for T1, T2 laryngeal primaries, mostly for oropharyngeal malignancy. And this was specifically for laryngeal primaries, a phase 2 study. But however, there was no evidence that one treatment was superior to the other, whether in comparison to larynx preservation. That was aimed for, actually. Now, if you ask, is there any trial which compared, now the standard of care today is concurrent chemoradiotherapy. So that is for laryngeal primaries, glottic, supraglottic. Subglottic primaries, we usually go for surgery because most of these patients have a compromised airway. For hypopharyngeal malignancy, other than EORTC trial, which actually compared induction chemotherapy with only radiotherapy. So concurrent chemoradiotherapy as a standard of care for hypopharyngeal malignancy is an extrapolation of the findings from the RTOG 9011, which was for laryngeal primary. That we need to understand. There is no trial other than the one that we are just about to discuss, which compared upfront surgery versus chemoradiotherapy, which is considered the standard of care. So here in this trial from Iyer et al. From the Singapore group, they compared upfront chemoradiotherapy with surgery, followed by adjuvant radiotherapy. Now, subsites, they included all subsites, that is oral cavity, oropharynx, maxilla, larynx, hypopharynx. The trial was halted prematurely due to poor accrual. And the median follow-up for surviving patient was for 13 years. So for larynx, oropharynx, and hypopharynx, they concluded basically that there was no difference in overall survival or disease-specific survival. So upfront surgery or chemoradiotherapy offered the same OS and DSS. However, they could not complete accrual for this study. So what the sample size was calculated for this benefit to be seen, it was never achieved. So, but however, subgroup analysis showed that sites such as oral cavity and maxilla did well when they underwent surgery rather than undergoing non-surgical treatment options. So this is the one rare trial wherein upfront surgery was compared with concurrent chemoradiotherapy for larynx hypopharynx, which showed no difference in survival. The other trial was attempted at Tata Memorial Hospital, wherein concurrent chemoradiotherapy was compared with surgery followed by adjuvant radiotherapy in laryngopharyngeal cancers, which include larynx and hypopharynx. It was started way back in 2005. However, this trial could not be completed. It was terminated prematurely due to slow accrual. There were around 60 to 70 patients that were accrued, and it had to be stopped because it could not, accrue the patients quick enough. So these were the only two trials which compared upfront chemoradiotherapy with total laryngectomy. Other than that, there were no trials. So this is one, ASCO recommendation where it gives recommendations as to how to use the larynx preservation strategies for laryngeal cancers for both early and advanced laryngeal cancers. So I would recommend all of you to please go through this, recommendations, which will give you point by point guidelines as to in which situations you can use what treatment for laryngeal cancers. Thank you for your patient listening. I can take questions if you have any.
Thank you, Dr. Shiva, for a very comprehensive and detailed presentation on such an important topic. So I think there is one question posted in the chat box. If you could take that, Dr. Shiva.
Yeah. So this question from Kinjal. So he says EORTC initially predicted 5-year laryngeal preservation was 35, but in long term, they reported that the actual 5-year larynx preservation was 22%. What may be the cause of this discrepancy? You mean to say at 10 years? That might be 10 years. I'm not sure if it is 5 years, Kinjal.
Kinjal, you can speak if there is any.
Yeah, if you can just explain that question.
Am I audible, sir?
Yeah, you are. Please go ahead.
Good morning, sir. Actually, in 10-year updated article, they told that the 5-year laryngeal preservation rate was 22%, and the 10-year laryngeal preservation rate was around 8 or 9%.
Yeah. So so that question, actually, they're not given any explanation as to why there was a discrepancy between 35% to 22% from what was initially stated and what was stated in the 10-year survival. I'm not sure if I'll be able to answer that question.
Okay, sir. Okay, sir.
Because there's no any reason related to, other than reporting. There must be some reason why they've reported it that way. which we cannot explain the reason for that, because these are different numbers given at 5 years. So they should be able to, that's a discrepancy which you are pointing out, which only they will be able to answer. I'm unable
Okay,
to.
sir.
Yeah.
Sure, sir. Thank you, sir.
If anyone else wants to ask the question, can please go ahead.
Any questions, please feel free to ask.
So if there are no more questions, so
yeah, so I just would like, if there are no questions, I just would like to make some concluding remarks. So that is, especially for the exam going, students, I think there's one question, role of CTRT for stage 4 larynx. So actually, if you ask me, there is no role for stage 4 CTRT in stage 4 larynx. I didn't want to bring this up because this might be a bit of a confusing or a controversial topic, which may not be useful for you in your exams. However, since somebody has asked this question for T4 larynx, so when there is a T4 larynx because of disease coming out through the thyrohyoid membrane, if that is what you're asking. If there's cartilage erosion, through and through cartilage erosion T4, it's surgery. There are various systematic reviews that have clearly mentioned that surgery followed by adjuvant radiotherapy offers better overall survival and the disease-free survival for these patients. Even the SEER database, the NCD database, there are 2 articles that we recently also discussed, which says that very clearly. Now, one thing that is controversial is when there is a T4 because of extension of disease through the thyroid membrane. When there is extension of disease through the thyroid membrane is when, and especially when there is an intact laryngeal function, is when there is a doubt. We are tempted to offer these patients chemoradiotherapy, but we have just published in JLO, Journal of Laryngology and Otology, wherein when we give chemoradiotherapy in such patients, they tend to do badly. Their overall survival is much poorer compared to when the patient receives surgery, even in these set of patients, when it is T4A, even in this. But this is a retrospective study, it has its limitations, but we have enough evidence in literature which suggests that upfront surgery for T4 larynx will be much better. I hope that answers the question.
So Dr. Shiva, I think there is one more study we had published some time back. This was again a retrospective review from Tata only. And it was the similar findings. We had those patients who were given induction chemotherapy for the patients who had this extralaryngeal extension through the thyroid membrane. They responded, and we could and then followed by CTRT had similar response to those without the extralaryngeal extension, without cartilage erosion. So what I mean to say is that induction chemotherapy, at least in the retrospective review, had some role in those patients where extralaryngeal disease was there through the thyroid membrane in organ preservation. But it was a small study of some 69 patients. So we need to have more data to justify that.
Yeah. So here we looked at patients who were upfront considered resectable. So these could be patients who were not considered resectable and may have received induction chemotherapy followed by chemoradiotherapy. But here, in this, whatever that retrospective study that I was talking about, we looked at 3 category of patients. One is when it was considered T4 because of extralaryngeal spread through the thyroid membrane. The second group of patients were considered T4 because there was extralaryngeal spread through and through the cartilage. And the third category was both. There was extralaryngeal spread through and through the cartilage and through the thyroid membrane. So when all these 3 categories of patients were considered upfront resectable, and however, they received concurrent chemoradiotherapy versus surgery, when the patient received surgery upfront, when it was considered resectable, they had a better overall survival compared to those who received concurrent chemoradiotherapy. So you need to understand this for residents, that this is a different set of patient compared to what Dr. Poonam is talking, wherein those patients were probably considered unresectable upfront and they received neoadjuvant chemotherapy and there was, disease response, and then the patient went ahead with chemoradiotherapy and may have had a better overall survival. I presume that is the case. use of non-surgical treatment increased over time. 32%. So why this corollary? Can you just explain what is that you're trying to say?
Sir, that what I wanted to say is that we like, sir, there's increased use of non-surgical methods.
So this is Quran, is it?
Yes, sir. Yes, sir.
Okay, nice name.
Yes.
So, sir, basically, sir, it fits in a lot of
So there are huge SEER data NCTP database for T4 larynx cancer, which has shown beyond doubt that upfront surgery works better than non-surgical treatment option. It could be concurrent chemoradiotherapy, it could be NACT followed by chemoradiotherapy. So
yes,
the data is clear in the side favoring surgery for T4 larynx, without a doubt.
Yes, sir. So, but even for T3 larynx, sir, even data from TMH, which we had done also, sir, that and what Sarvani ma'am and the one which is practiced in TMH is that, ma'am, so we look for the volume of the disease and also the dysfunctionality of the larynx.
Volume of the disease, that was an older concept. Nowadays, I think Anuj is there online. I'm not sure if he's still around. Anuj can just add to it. I'm not sure if they really look at the volume of the disease to treat the cancer. Anuj, do you look at it?
Yes, sir. So the thing is, sir, in hypopharyngeal cancers, sometimes the ones which we are talking about the when it goes through the thyrohyoid membrane, when there is exolaryngeal spread, if the bulk of the disease is more, our volumes treated also will be higher. But the thing is, even after induction, we'll have to treat the same volumes which were present previously. So that is why, as such, sometimes we go upfront and treat those patients unless it is not very bulky, or else we will give induction and see what happens, the response happens, and then proceed towards CTRT. But mostly our induction chemotherapy will be for patients, sometimes if they have very bulky disease through the through the thyroid membrane, or sometimes when there are large neck nodes, which we feel may increase the volumes for radiotherapy. So these are, but when there is cartilage erosion, then the patient directly goes for surgery. So that is what we normally practice, like on the clinical practice.
Yeah.
So, sorry. Yeah, so sorry. So sorry to I just wanted to follow up on Anuj's comment. I wanted to ask Anuj again that the book states about the inverse proportion of the volume of the disease with the Mendenhall papers and all, which used to say that RT depends on the volume, and there was there's an RT cutoff of the volume and all, which we used to quote. But is that still holds true, that you all still see the volume of the bulk of the disease at the time of in deciding whether is it how like you just did mention that you all do see whether it is, but is it still detrimental prognostication wise?
Yeah, so I got your question. So the thing is, especially when the volumes are too large, the toxicity is also associated with the treatment. That is also going to have an implication. So that is why when you treat like large fields, the toxicities also will be higher. So that is why we always see clinically and radiologically what is the bulk of the disease, whether these are amenable for upfront CTRT, and then we proceed. So that is why I was telling you, sometimes we have these large nodes which may seem to be very it may be difficult for getting a response after complete radiation. So sometimes when you have reduction with the volumes, then achieving a complete response will be better, because sometimes when you treat this huge volumes, the response may not be complete. So you may still have a partial response and the patient may have to go for neck dissection or so after the radiation treatment. But when you have a good response, when the volumes are reduced, that may actually help in achieving a better response. So that is what. So what you told is what you try to ask is that does the bulk of the disease actually affect our radiotherapy treatment, right? So this is what is my opinion on this.
Okay. Yeah.
I hope that answers.
I think it's very clear, just for the residents, so that they don't get confused, is that T4 larynx upfront surgery is the treatment option.
Yes.
You can consider other treatment options in various situations. When you consider the patient is like borderline resectable or unresectable, you can give induction chemotherapy. Now, induction chemotherapy in T4 is not given for larynx preservation. That we need to understand. Induction chemotherapy is given
Yes,
for converting this borderline or unresectable to probably resectable sort of a lesion. And then maybe you can reevaluate for surgery. If surgery is not a feasible option, you can consider chemoradiotherapy if the patient still has a functional larynx. Now, all we need to know in T3 also, the TMH data says surgery is better than non-surgical option, but that's a retrospective data. But whatever data we have for T3 is in favor of non-surgical treatment option as of today. Even the SEER database is sort of hinting towards surgery, but the randomized trial data are favoring non-surgical treatment option. But having said that, even if T3 laryngeal or hypopharyngeal malignancies, we need to look for the laryngeal functional rates. If the patient is not tracheostomized, if the patient is not aspirating, then only the patient should be considered for chemoradiotherapy. If a T3 has a tracheostomy in place, then because of stridor and he has swallowing issues, has a Ryle's tube, I think T3 also patients would end up going for a total laryngectomy. So here, in the organ preservation scenario, the function of the larynx prior to starting the chemoradiotherapy is crucial. So we need to evaluate the patient for the speech and swallowing as you decide for this sort of treatment.
Yes, sir. A very right point exactly raised. So functionality of the larynx, that should be the most important thing before you consider for any organ preservation strategy. So not that all this PAS 7, 8, like there is like high rates of aspiration when we contemplate aspiration. So those are not the ideal candidates. So we have to see everything. We have to see the disease. We have to see the functionality of the larynx, everything, and then make a decision on whether to go for organ preservation or not. So yes, sir. So one more thing I just wanted to add, you were talking about the TAX 323 and 324 trials, no, sir?
Yeah.
Yeah, so in that, actually in the first one, 323, so like you told, it is the patients receive 3 weekly PPF for 4 cycles followed by like RT. In this, there is no concurrent chemo, but only thing is that there was actually having different fractionation. So some were treated with conventional, some were treated with accelerator, and some were with hyperfractionation. Just wanted to add that point. Yeah. And in the 324, it was CTRT with weekly carbo. So just the difference between the radiation therapies. Yeah.
Thanks for that. Thanks.
Okay, just one on.
Yeah. So there's another question. Any difference in organ preservation when considering subsites of larynx or just stage and functionality only? I think it's stage and functionality more than anything else. Subsite of supraglottis versus glottis within the larynx has not shown any major difference except for in the VA trial where only RT was used. Mostly subglottis goes for surgery because these patients present with difficulty in breathing, so they're not considered for chemoradiotherapy. They're always considered for surgery in majority of the cases. So it's based on the stage and the functionality. Stage being more for the T stage. Any other questions? I think it's 10:30. If there are none, we can wind up. Dr. Poonam.
Yes, thank you. I think with this, we will conclude today's presentation. So I thank you once again, Dr. Shiva. It was a very, I think, detailed. We discussed a lot of very important points, which are very important for the exam going residents and students. And that was one of the reasons why I kept this class around this time. And I knew you will do the best justice to this. So with this, I request you to be available for future also for our Saturday academic classes. Thank you so much.
Thank you for the kind words. Thank you all.
Thank you. Thank you so much.